Every day, the human heart beats around 100,000 times. Each individual heartbeat relies on a synchronized sequence of electrical triggers, shifting pressures, and mechanical responses to move blood through the body. The foundation of this synchronization is the pressure gradient. Blood moves strictly from zones of higher hydrostatic pressure into zones of lower hydrostatic pressure. In this schematic of the left heart, the gauges show how pressure alone dictates flow. Cardiac valves are not active muscles that push blood. They are passive structural gates that open and close exclusively in response to the hydrostatic pressure differentials across their leaflets. The resulting flow is a continuous domino effect, where these shifting fluid pressures dictate every physical movement in the system. The cycle begins with the electrical P wave. This trigger initiates atrial systole, where the atria contract to push a final 20 to 30% of blood volume into the ventricles, reaching the end diastolic volume, or EDV. The P wave is followed by the QRS complex, which triggers ventricular contraction. As the ventricle squeezes, its internal pressure quickly exceeds the pressure in the atrium. This pressure gradient snaps the mitral valve shut, producing the first heart sound, S1. This initiates isovolumetric contraction. Because the aortic valve is not yet open and the mitral valve is closed, the ventricle is a sealed chamber. As the walls squeeze the fluid, the internal pressure spikes from 8 to 80 millimeters of mercury, but because the chamber is locked, the volume cannot change. This phase ends only when ventricular pressure defeats the pressure in the aorta. This bursts the aortic valve open, entering the ventricular ejection phase. As blood exits, the internal volume drops to its minimum level, the end systolic volume. The T wave then initiates relaxation. Pressure plummets below the aortic level, snapping the aortic valve shut to create the S2 heart sound. The ventricle enters isovolumetric relaxation, where all valves are closed once more, until the pressure drops low enough to permit refilling. These 6 phases form a closed-loop mechanism, building intracavitation force to move fixed volumes of fluid against high resistance. The Wiggers diagram is the master graphical timeline of this process. It overlaps electricity, pressure, volume, and sound along a single horizontal axis. The vertical alignment shows the direct cause and effect of the cycle. The QRS wave leads directly to the point where ventricular pressure crosses atrial pressure, which mechanically forces the mitral valve closed and triggers the S1 sound. At the end of systole, the green ventricular pressure line drops below the red aortic pressure line. This forces the aortic valve close, generating the S2 sound and the dicrotic notch on the pressure tracing. Rather than a static chart, this is a unified narrative of pressure dictating physical movement over time. The pressure-volume loop plots the left ventricle's internal pressure against its volume. The 4 corner points correspond to when the mitral and aortic valves open and close. Following the loop counterclockwise traces a full cycle. The horizontal width represents stroke volume. Subtracting the 50 milliliter end systolic volume from the 120 milliliter end diastolic volume leaves a net stroke volume of 70 milliliters. The ejection fraction is the percentage of that starting volume that is successfully pumped out. In this case, 70 milliliters out of 120 results in a normal baseline of 58%. The total area inside this loop represents the ventricular stroke work, which is the raw mechanical energy the heart expends during each beat. Cardiac output is the final metric of this performance. It is the product of heart rate and stroke volume, measuring the total volume of blood pumped per minute. The heart scales this output using the Frank-Starling law. Increased venous return stretches myocardial sarcomeres toward their optimal length of 2.2 micrometers. This stretch increases the force of the subsequent contraction, immediately elevating stroke volume and cardiac output to accommodate the increased blood flow. The heart is a highly adaptable pump governed by pressure, adjusting its mechanical output beat by beat to maintain the human system.